Now, an hour of exhausted people of our nation mired in toxic partisanship. Left versus right, us versus them. While we pay to keep our politicians fighting, how do we, the people, rise up and solve the great challenges of our time? We do it by embracing freedom and liberty. There may be no such thing as a free lunch, but this hour is as close as it gets. Welcome to A Free Solution.
Welcome to A Free Solution. I'm Kevin Wolf, your host for today. Thank you so much for joining us. Appreciate you being here today. We are not live on WYSL today. It's a pre-recorded episode, but you can always send me an email, contact@afreesolution.com. But glad you guys are listening. Shout out down the line to our friends over at WACK out in Newark and WENY, the Patriot down in the Southern Tier, and our friends listening to the premiere online as well. I will be checking the comment section, and we can continue this discussion afterwards. So today's topic is about, well, it's about birth. And as listeners of this show know, I've been thinking about that a lot lately because my son was born pretty recently, and we had an interesting experience. And so thinking about things like, why is the maternal death rate so high in the United States? What happens to women and consent in the delivery room? What happens with how much choice do you have over the medical decisions that are made about you and your body if you're a woman giving birth, or even, if you're a husband just watching it happen? Like, how do you participate in that process and make sure that you can advocate for your wife or partner who is having a child? So to talk about that today, I have Dr. Lauren Hall, who's a professor of political science at Rochester Institute of Technology, and also the author of The Medicalization of Birth and Death, which came out in 2019. And so Dr. Lauren Hall, thank you so much for being here today.
Thank you for having me. It's great to be here.
Yeah, so the article that caught my attention, it was just reposted over on Students for Liberty, but it was an article that says doctors violate American women's rights in delivery rooms every day. And so that's what I wanted to bring you on about to talk about. And to give some extra context to this, I don't think this is just important for women or for, soon-to-be fathers or recent fathers. I think this is important for everyone because I think a lot of the issues that you end up highlighting in this article and some of your other work kind of impact the entire healthcare industry. So this is something that's important for everyone listening today. So even if you're not thinking about birth and the delivery process, this is still relevant to you, and I hope you guys can learn something today. But let's talk about what that article was and what happens when giving birth. And what happens with consent while giving birth?
Yeah, great question. So that article came out, I think I did a series of articles for Learn Liberty for Women's History Month, but it was also work that I was doing related to that book that you mentioned, my most recent book, The Medicalization of Birth and Death. And in that book, I really wanted to try to tease out what, we often talk about the problems associated with sort of healthcare in America, broadly speaking. We have a lot of challenges when it comes to maternity care. We have one of the highest maternal mortality rates in the developed world. We have some of the highest infant mortality rates in the developed world. So there's a lot of sort of weird paradoxes, and that's compounded by the fact that we spend more on these kinds of things than other comparable countries do. So we're spending a lot and getting not great care. The other piece of this, though, that came out while I was doing research is that we're spending a lot and getting not very good care, and we're violating people's rights a lot in the process. And that struck me as even more bizarre. And so one of the things that I was looking at is, and this actually started with a survey that I did. It was an anonymous Facebook survey, just asking people about their experiences during birth and in the labor process. And what I found is that in the context of the delivery room, sort of women's preferences fly out the window. It really becomes this woman's body is a vessel to get this baby out of, right? And so whatever that vessel wants is irrelevant. The question is how to get the baby out. And I've given birth 3 times. So I have some of this, some personal experience in this area as well. And in fact, some of this research was animated by my own experiences in hospitals giving birth. And part of it, and you pointed out, I think, a really important piece, which is this isn't just restricted to women, but birth is one of the primary and most intensive interactions that we have with the medical community. And so that's why I think a lot of these issues really balloon out when we start talking about maternity care in general. So anyway, as part of this research, I just started collecting stories of people's experiences in the hospital. And what I found across the board was that the concept of informed consent really doesn't matter. So what you want to happen to your body does not really make a difference with how you're treated in the hospital. And it also doesn't seem to matter how medically risky you are as a patient. So it's not that informed consent balances against medical need, which is a narrative I hear from a lot of people. It turns out that it's much more complicated than that.
So what do you mean by that? Like, can you kind of describe an example of where informed consent might break down and what that looks like for people experiencing this?
Yeah. So the most common narrative I hear, and this is the most understandable case, is, for example, say that you're pregnant, and all of a sudden you find that something really bad is going on. Right? There's a serious complication. Your preferences may not, in order to do an emergency C-section, for example, your various kinds of preferences that you had may fly out the window. And I think most women would say that that's fine, right? They're willing to sort of capitulate in a variety of ways because of the emergency nature of the situation. So that's very often how I hear particularly men talk about it, as though, well, yeah, informed consent matters, but not if you're trading off for medical need. The examples that I gave in the article that you kind of kicked us off with were cases where there was no medical need to override informed consent. Instead, you have cases of doctors abusing women, in many cases as a result of outdated hospital protocols, sometimes as a result of other kinds of limitations in the hospital context. One of the examples I gave in that article was one of Kimberly Turbin. And this made national headlines because it was so egregious. But she was a sexual assault survivor and had very specific preferences about how her body would be treated during labor and delivery. And she told her doctor that she did not want an episiotomy. And episiotomies are essentially a widening of the birth canal, and they're pretty much unnecessary in the vast majority of births. They used to be routine, but they've actually been demonstrated to be very damaging in a lot of cases.
They're the way, at least the birthing classes that we took, mostly they were done for doctors' comfort and convenience,
Yes.
more than medical necessity.
Yes. And they can lead to really serious disabling issues later in life. They can lead to incontinence and all sorts of other things because they essentially just open things up in really dangerous kinds of ways. So she had talked to her doctor about her preferences during birth, and her mom was videotaping the birth because she wanted it videoed. And the doctor basically said, "I'm going to cut you now." And she said, "No, what are you talking about? We didn't agree to that." And so you can see the video. I wouldn't watch it if you're at all uncomfortable with things like this. But not only did he override her refusal for the episiotomy, he then proceeded to cut her 12 times and did permanent damage to her pelvic floor. And at the time, she couldn't find any lawyer to take her case. So it was a situation where she felt clearly that if you had done this to someone on the street, right, it would be assault.
Yeah.
And yet in the context of the hospital room, for some reason, even though there was no medical need, the doctor didn't even claim medical need. He just said, I'm gonna do this episiotomy, overriding your consent. And so she ended up finally being able to find a doctor who would take it as a battery case. So it was a civil claim, not a malpractice claim. And she finally got a settlement much later, but it took years and years.
Wow.
So those are some of the violations that we're talking about. Again, we're not talking about situations where you need to do an emergency C-section in 30 seconds in order to save both the mother and the baby. These are not the violations we're talking about. We're talking about really serious violations with no medical need.
Yeah, because I think we can understand that there's certain situations where you've got to act quickly, and usually you go in understanding that that's going to happen, and you hope that you can trust your doctor and the providers around you to discern the difference between, no, I'm not consenting to this medically unnecessary procedure, and yes, we have to do an emergency C-section because, you know, your life or the baby's life's in danger. Like, let's move ahead with this. So we are running out of time for this segment, but when we come back, we'll talk about rights that women have in the delivery room, and advocacy, and some more stuff going on, and what we can start to do to change some of this. All right, so thanks again for joining us here on A Free Solution. We're here with Dr. Lauren Hall. We're talking about birth today. Thanks again for joining us. We'll be back in just a few minutes. All right, welcome back to A Free Solution. I'm Kevin Wilson, your host for today. Thank you so much for joining us. We're here with Dr. Lauren Hall, who's the a professor of political science at Rochester Institute of Technology, and also the author of The Medicalization of Birth and Death. And we're talking about birth today. Again, something that's been on my mind, and we're talking about consent in the delivery room, and it is something that's important. And I do want to point out, like, you know, because I will share a little bit about what happened with me and my wife. We did end up having, it wasn't quite an emergency C-section, it was more like an urgent C-section, because there's something wrong. There's something wrong with the baby, and they're like, hey, you need to get this baby out in the next couple of days. There's a risk here. Here's what it is. We talked about the options. The doctor that my wife had was excellent, reviewed everything, made sure she was comfortable with everything, and the C-section was the way to go. So that's what we ended up doing. We had some other terrible stuff happen. Maybe we'll get into it, but I do want to talk about with Dr. Hall here, what rights women have to talk about consent, you know, when they're in these medical procedures. Like, how can both mothers and their partners advocate for that? So what are some tips you might have for people in these situations?
Yeah, so the first position's a little bit, it's harder to, it's a preventive rather than something that's going to help in the moment. But, you know, make sure, as it sounds like you and your wife were, like, make sure that you trust your doctor. Make sure that you understand what incentives your physician has. I, for example, with my first pregnancy, had a doctor who just made it really clear that she did not care about my preferences during labor and delivery. Yes. So I thought to myself, that's a really bad sign. Right? So I ended up switching doctors, and I found a doctor who really was very great at communicating, very interested in making sure that as far as was feasible, we would have the kind of birth that I was looking for. And one of the benefits that I think having that trust between your physician creates is that you then don't distrust their medical advice. So there's one of the problems in the hospital context is that there's a huge asymmetry of information between mothers and fathers and the medical staff. By definition, these are specialists. They're people who have gone to medical school for many, many years.
You assume, they know what they're talking about. So like,
exactly.
Who am I to question this? And they make you feel that way too.
They do, yeah. The problem, though, and this is what a lot of birth advocates and researchers have pointed out, is that a lot of the restrictions on women's bodies and restrictions on consent in the hospital context are not, in fact, based on medical need. They're based on the efficiency of the hospital ward. They're based on hospital protocols. A lot of them are actually based on reducing liability for the hospital and the doctor over time. So these are not rooted in medical practice. They're rooted in these other institutional needs. But as a patient, especially because of the episodic nature of birth, like, you don't give birth every week. So it's not like you have this deep knowledge of the institution. When you show up at the hospital, you're ignorant of all of this, right? You don't actually know what's medically necessary, what's just protocol, what's just liability fear. So that's why trusting your provider is so crucial. You've got to trust that they're going to try to work with you and be transparent about what is just crap liability stuff that you have to put up with because you're giving birth in X hospital, and what is actually medically necessary. So I switched to a provider who I felt very comfortable with. And if she had told me, Lauren, you need a C-section, I would have said, absolutely, right, fine. I trust you because you are the expert. Whereas if my previous OB had told me you need a C-section, I would have said, well, do you want to go golfing? Like, what is the reason that you're demanding? Like, I don't trust your motives here.
Right.
So the first thing is, obviously try to find a provider that you trust. That doesn't always happen. And again, because of the nature of medical care in the United States, it's often hard because you don't necessarily know who you're going to be delivering with. So even if you have a great rapport with one doctor, you may not see that doctor ever again. So the crucial thing to remember is that the hospital environment is in fact fairly coercive, but it's not fully coercive. You do in fact have freedom of exit. Very often I'll hear stories of mothers who are pitted against their unborn child, basically being threatened. If you leave the hospital, we'll call CPS, we'll investigate your other children, for example. And some women are actually told that they cannot refuse treatment, that they're not allowed because their unborn child has certain rights. That is legally incorrect. So a pregnant woman can reject any treatment, even if it's necessary to save the life of her unborn child. Obviously, we hope it never gets to that point, but women in the United States do in fact have blanket rights to refuse treatment even when pregnant. So that's the first basic legal piece. Now, what that looks like in practice, of course, is much more complicated, because typically when you're in labor, you're in pain, your mobility is limited. You may feel as though you can't leave the hospital against medical advice. You can. You also, though, within the hospital context, have the right to request a different nurse. You have the right to request a different doctor. You have the right to ask for a supervisor to come and at least be a witness. A lot of hospitals have been trying to limit, for example, videotaping. And that's actually a legal question right now, whether they can legally limit women from videotaping their own labor and delivery. And that's obviously just for liability issues. So you have the right to push back on all of those policies. And then the other thing that I highly recommend is to have a doula on during your pregnancy, if possible. The reason doulas are so important, and I think there's a lot of misunderstanding about what doulas do. The real crucial piece for me of doulas is that they have institutional knowledge about those hospitals that new parents don't. So that doula will be able to tell you, oh, this particular policy is total bullshit, right? You can reject that. Or they'll be able to say, no, that it's just liability, it's just bullshit, but you still have to listen, right? You still have to do it. So they will be able to be more honest with you about what is legitimate kinds of policies and what are much more illegitimate kinds of policies, and they can help you navigate that. So I used a doula for my first two births, and she was just enormously helpful at giving me information about what to expect. So she helped overcome that informational asymmetry that we all face when we walk into the hospital scared and in labor and afraid. And my husband, we've mentioned sort of the role that men play, but my husband was in a similar situation where he didn't know, he was scared. He was excited to see this new baby. The last thing in the world he wanted was for anything to go wrong. So his instinct was trust the medical professionals. But he also has a wife who he respects and wants to see her treated respectfully and wants to make sure that she's comfortable with the experience. And so the doula was able to help both of us just know what to expect and get over that asymmetry. And then finally, doulas can be really important witnesses to coercion and violence. So there's been an enormous body of literature coming out from doulas who are watching their clients be coerced and violated in the hospital context. And that's some of the only data that we have about how common this is, because doctors aren't going to report it. Nurses aren't going to report it, right? The people who are actually doing the aggressing aren't going to report it. So you've got to have these third parties involved. And I think doulas can be really important in that realm too.
Yeah, no, and that's a lot of great information there. And having someone who knows, like, again, having just gone through this process too, like having someone who knew, we kind of wish we'd gotten a doula. I mean, it's different when you're going in for like a quick C-section, but being able to navigate that process. And we ran into an issue where they were trying to, and I'm sharing this with my wife's permission too, but they were trying to discharge her. And she was trying to say, hey, I'm having these symptoms of preeclampsia, which is very serious. You can end up having a stroke or a seizure if it isn't treated. And she's like, hey, I'm swelling. I'm, puffing up in like my arms and my face, and her blood pressure is going up. And we had to keep advocating to the doctors, like, hey, something's wrong here. And they're like, oh no, you're a first time mom. You don't know what's going on. Like, that's just all normal stuff. Don't even worry about it. And eventually we had to go and find a nurse who would advocate for us. Be like, hey, listen, her blood pressure is normally like very low, and now it's in the like 150s and 160s, and the doctors are just saying like, oh, she's just stressed because the baby's in special care, and like, no, we need to do something about this. So know your rights, know when something's going on, and yeah, like having someone there to help you understand that stuff and help you know when you can navigate. And luckily we got some advice ahead of time to do some of this stuff, because that and luck we had a nurse at the hospital we delivered at who finally took my wife's concern seriously, because it probably saved her life, because the first doctor said no, not a big deal, and we had to go and find other doctors to help intervene in something. And oh, we did a test, and yeah, it turns out it's very serious, you're going to go on a mag drip in like 2 minutes. Okay, great. So that type of stuff, and that happens throughout the birth process and afterwards too. Know what your rights are, know who you can talk to, know you can request second opinions from other people, and you got to kind of trust your gut. Now, I know the doctors, they're kind of in a position like, oh, these people don't know anything. Like, I know I've done this every day. Who are they to question my authority? You know, and most of them care a lot. I'm not saying that, but every once in a while they're like, oh, it's not a big thing. They're just being worry warts. But you got to know, and for the mom, for the baby, and I'm saying this to the partners out there too, husbands and other partners. Yeah, kind of have your mom's back there, have your partner's back there when she's having a baby. So we're just about to wrap up this segment here. Again, we're joined by Dr. Lauren Hall, who's a professor at RIT and the author of The Medicalization of Birth and Death. And we're talking about, kind of consent in the delivery room and consent throughout the whole birth process. And when we come back, we're going to talk about, well, what are some of the solutions that we have to be able to give other options to new parents, and what are some of the policy barriers in the way of that? So thanks again for joining us here on A Free Solution. We're going to be back in just a few minutes. Welcome back to A Free Solution. I'm Kevin Wilson, your host for today. Thanks again for joining us. We're here on WYSL and not live today, but you can always send your questions and comments to me over at contact@afreesolution.com, or follow us on the Facebook page at Free Solution, Kevin Wilson Libertarian. It's going to be posted up there, YouTube channel, Free Solution, and it'll probably be posted on Twitter too. Thanks everyone for listening. Thanks for your comments. And also shout out down the line to our friends over at WACK out in Newark and WENY, the Patriot down in the Southern Tier. We love having you here as well. And today we're talking with Dr. Lauren Hall, who is a professor of political science over at RIT, and also the author of The Medicalization of Birth and Death. And we're talking about, now we're talking about solutions to what we were talking about in the first half an hour of this show. Is there's issues with consent during the delivery process, kind of asymmetry of knowledge in the medical process, or how do you advocate for yourself when you're in that situation. And now let's talk about what are some solutions to this. What are alternatives to the system as it exists now, which is very hospitalized, very medicalized? What could this look like instead?
Yeah, so that's a great question. One of the things that came out while I was doing research that I actually didn't quite expect it to go in this direction, but one of the things that seems to me really clear is that the reason that women have so few options during birth and why they're so limited by the specific provider at the specific hospital is that we've essentially regulated all other options out of existence. So we have a long history in the United States of eliminating various alternative providers, namely midwives, via licensing in various states. And this is despite the fact that midwives have very, very good outcomes for both maternal and infant safety. So there's no medical reason not to support midwifery for low-income births. But we've made it very, very difficult for midwives to get licensed in various states. For example, there's a midwife in the Finger Lakes area who's facing 90 felony charges for practicing medicine without a license because she was serving Amish and Mennonite women. So these are women who don't have any other option. They're not near a hospital. And now she's, again, facing 90 felonies for practicing midwifery. So there's serious problems with both sort of the licensing issues. But then the other problem, of course, and this is New York State, is that we have extremely hyper-regulated healthcare system. And one of the results of regulation is that it tends to consolidate markets in general, and it leads to a kind of monopoly on care. So over 98% of women give birth in hospitals. That number is actually even higher in New York State because we don't have alternatives like birth centers, which we can talk about in just a second. But we know, for example, that home birth and birth center birth can be very, very safe for low risk women. Obviously, if you're high risk, you want to be in a hospital where you have specialists. But the vast majority of women don't have that option. So when I was pregnant with my first daughter, I looked for birth centers in the Rochester area, and I was completely shocked to find that we have none. And then I found out that the reason for that is that the New York State has what's called the Certificate of Need process, which is a process that's been in place since the late 1960s, that essentially allows the government to decide what kind of healthcare is going to be able to enter the marketplace. So the Certificate of Need process demands that in order to be a healthcare clinic or hospital, you have to jump through these regulatory hoops. In the case of birth centers, you have to, it's basically essentially a 2-year process and hundreds of thousands of dollars. And so for most midwives who are entrepreneurial small business owners, you don't just have $500,000 laying around, but hospitals do. So hospitals and corporate clinics can make it through this process, whereas entrepreneurial small business owners cannot. So we've really regulated alternatives out of the system.
What's the justification for certificate of needs generally? Like, why do governments across the United States require those?
They started in the 1960s. New York actually had the first one, and then the federal government mandated them because they thought that by regulating the market, you could lower prices. So it was a way to try to reduce what governments thought would be unhealthy competitions between hospitals. So the theory was if you have too many hospitals in an area, they're going to be competing for a pool of patients, and they're going to raise their prices to make up for the fact that their market share is diminishing. Well, it turns out that there's lots and lots of research that certificate of need laws do not, in fact, lower healthcare prices. They don't improve quality because that was never what they were supposed to do in the first place. What they do is they increase the cost of entering the marketplace so much that they create monopolies. So in the New York case, and actually in most states where certificate of need laws exist, essentially you have a system where an entrant, someone who wants to enter the marketplace, has to ask permission of existing business owners, i.e. hospitals, to see whether they are allowed to enter the marketplace.
And those existing hospitals might have some incentive to maybe not be okay with that.
Exactly, right. So anyone who's familiar with market principles knows that this is a terrible idea, right? So all that has happened is that we've created this, we've really consolidated medical power and created a medical monopoly. Which of course means that women who are giving birth have just very, very few options, right? You have your local hospital or nothing. In some cases, you might have a home birth midwife who serves your area, but those are very rare because the licensing requirements in New York State are so onerous. So really, it forms a kind of funnel that you just shove pregnant women into, and they end up at their local hospital, not because it's the best place to give birth, but because it's the only place in their area to give birth. And we actually know from the research too that outcomes vary really dramatically, not based on women's risk factors, but based on the hospital that they give birth at. So just as one very quick example, your risk of getting a C-section in the United States has much less to do with your medical risk as a pregnant person than it does with the specific hospital that you give birth at. And the C-section rates differ by as much as 70%. So you could be giving birth at a hospital with a 50% C-section rate.
Yeah, and most of the local hospitals, at least the ones in Rochester, do post their C-section rate. So you can look it up. You can see what it is. And I think the average for the United States is 30%, but I think the World Health Organization says it should be closer to like 10 to 15%. Mm-hmm. So it's much, much higher than it probably ought to be. And as I said, some hospitals, whatever doctors are there, are just making the decision to have C-sections more often, and you can see that reflected in their numbers as well. Mm-hmm. Mm-hmm. So we have these certificates of needs, and so what happens with with these birthing centers? Are they legal in New York right now? What is
They are now. So for a while they were not. That you could have a physician-led birth center. So New York State has, at last count, I think we have 3 birth centers in the entire state of New York. All of them are owned by physicians. There's not a single one that's run by midwives. And that was because until very recently, it essentially limited birth centers to being physician owned. And that creates its own conflicts, of course, because physicians don't get paid that much for births in a birth center. They're going to be much better compensated in a hospital context. So very few physicians want to own birth centers. So it kind of creates this weird choke point that shouldn't be there. So a couple of years ago, they actually did, in fact, pass a midwifery bill, a midwifery birth center bill. But then the Department of Health dragged its feet for 3 years, I think 4 years, before creating the actual regulations for the birth center. So essentially the legislature had said, we can have midwifery birth centers, but we don't have a regulatory process to open them. So of course you can't open a birth center if you don't have a regulatory process to open it.
Can't meet the regulations if they don't have them.
If they don't have them. So we were in a holding pattern until March, I think, of 2020, because we were in this pandemic. Women were being forced to give birth alone in COVID infested hospitals without their husbands or partners or doulas because of the limitations. It was really horrific. And so they put together an emergency maternity task force to try to figure out how to get these regulations through. And so finally they got some regulations through. And then the midwives and doulas who had been hoping to open birth centers looked at these regulations and they said, well, there's no way that we can meet them, right? These are regulations that are best fit for hospitals, right? A 2-year wait, hundreds of thousands of dollars. Sure, hospitals can do that.
All right, so we are coming up on a break, but we'll talk more about like what those barriers are and then maybe what could be happening to help fix that, but we'll see. All right, so thanks again for joining us here on A Free Solution. We're here with Dr. Lauren Hall, professor at RIT and author of The Medicalization of Birth and Death, and we're going to be back in just a few minutes. All right, welcome back to A Free Solution. I'm Kevin Wilson, your host for today. Thank you so much for joining us. We're joined by Dr. Lauren Hall is a professor of political science at RIT and the author of Medicalization of Birth and Death. And we're talking about, well, the whole birth process, the healthcare industry, all this stuff. And we were talking before the break, we were talking about why it's so difficult for midwifery groups to open up their own birthing centers, having these alternative to the hospital systems for people who want them for low risk births. And New York State had dragged its feet on making all these regulations for years. So you couldn't open one of these places if they didn't have regulations that you could meet. And then once they did come up with regulations, it was so expensive and took so long that no one could qualify. So what do we do about that? And what's the current status of what's happening here?
Yeah. And one quick, just to show you how complicated the system is. I mean, one reason that you have to be licensed, like a midwife could simply do home births in her living room and you could call it a birth center, but you need to be licensed in order to get Medicaid reimbursement. So there's this the licensure is really linked to the reimbursement process, and insurance companies won't reimburse you for facility fees, for example, unless you're an Article 28 facility in New York State. So it's enormously complicated, and it just means that every piece is contingent on every other piece, which is why which is why there are so few birth centers in New York.
And quick aside, is it just easier to go through this process if you don't go through Medicaid or insurance? Like, are there like private pay providers who do this sort of thing? Like, because I've heard about it happening. Apparently, the owner of this house before I lived here had birthed a child here, so I know it like happens. But
yes, so that would be a home birth. And it would be typically home births, if they're covered by insurance, which many insurers do not cover home births. You only get paid for the birth itself, and you don't get what's called a facility fee. So you don't get the additional, for example, if you wanted to run a birth center in your home, you wouldn't get any of the facility fees to help keep the birth center going, right? To keep the lights on, to pay for any of the infrastructure. Facility fees are themselves kind of controversial right now for a lot of important reasons. But the big issue is that midwives simply can't compete with, it's not even a question of competition. they cannot get adequately reimbursed unless they have this additional facility fee, just given how low the reimbursement rate is for birth.
Interesting.
Yeah.
So what's next with this? Where do we go
Yeah.
from here?
So yeah, there's a couple bills actually. So the essentially, there's a couple bills going on right now that there's one in the Assembly and one in the Senate. The one has passed the Assembly. That's actually A259, Assembly A259A. And that has passed the Assembly unanimously, I believe. So there's support for this. The Senate bill is currently in the Health Committee. So that's Senate 1414A, if I'm remembering correctly. And those are bills to facilitate the licensing and essentially to allow birth centers to apply for national accreditation through a national accrediting body, which would replace the onerous state licensing. So the advantage to national accreditation is that you have private accreditation agencies that their accreditation process is really evidence-based, right? Here are the things that really impact maternal and infant outcomes. These are the things that we want to make sure you're doing right. So you can apply for that accreditation, get that accreditation, and essentially get around the certificate of need process in New York. The reason that's really important is that the certificate of need requirements, and I know we mentioned a couple of them, but they're not only just inappropriate, but they're not requirements that have anything to do with maternal or infant safety. So for example, one of the requirements is that you have a space rented for a year before you start the certificate of need process. So you just have an empty building that you're paying rent on for a full year before you start the application process. There's no need. Like, that's not something that contributes to maternal or infant safety. And especially in places downstate, that's simply prohibitive. You can't rent a space in Brooklyn for a year without pulling an income. No business owner.
That's like setting $100,000 or more on fire.
Yes, exactly. Just a big bonfire of money. So the accreditation process really is focused on maternal and infant outcomes. It's not focused on these like random bureaucratic requirements. One of the requirements is an architectural requirement through the Department of Health that it limits ceiling height, but it even affects office space. So like your ceiling has to be a certain height. Like it's crazy. Elevators have to be able to fit gurneys, despite the fact that pregnant women in birth centers don't use gurneys. You walk in and you walk out. Like that's the whole point.
Yeah.
So it's all of these really inappropriate regulations that are much better suited for hospitals than they are birth centers. And so the goal of these bills would be to essentially get rid of all these irrelevant regulations and really focus on the requirements that improve maternal and infant outcomes. And so that's what the national accreditation agencies go for. And so if this bill passes, we would have instead of facing this just preposterous, these extra hurdles, you would just be facing the normal hurdles that an entrepreneur would face, which is finding the right location, finding backers, all of that stuff, right? Which is still hard enough without adding hundreds of thousands of dollars of New York regulations on top of it.
Yeah, I mean, like some of those regulations, like who wrote those? Like, why did someone advocate to keep some of that stuff in like the ceiling height thing? I mean, maybe I'm sure that someone can give me a reason, but I don't understand it, and I don't see why that should be a barrier to opening. And I like the idea of private accreditation for these type of things, like where there's not a conflict of interest in the same way that you see with certificate of need laws, where you have an obvious conflict of interest with local hospital system that is deciding whether or not to allow more competition to them, and you focus on quality of care. And then if the market can take it, then you're going to stay open, and if you have too many of these centers or your center isn't good quality, then well, you're probably not going to survive in that market anyway. So why not just let more of a free market system exist for birth?
Exactly. Yep. And I'll just say too that these regulations we've been talking about the birth context, but these regulations are extremely problematic across the healthcare context. So these are issues that face, and you mentioned the ceiling height things. I mean, hospitals are some of the most regulated industries in the nation, and the barriers that regulation creates to high quality healthcare. I mean, every dollar you spend dealing with state regulations is a dollar you can't spend on patient care. So we're really making a very poor trade-off when it comes to how we think about healthcare. And a lot of the regulations are in fact just straight up anti-competitive regulations. They're not even there for patient safety.
Yeah, so nothing to do with safety. It's just someone wrote them in there because they're like, well, we can comply with this because we're a big hospital system, but I know
Exactly.
that the small time doctor is not going to be able to do this. And so that drives up healthcare costs across the board, not just in this specific instance, but all over. We're seeing higher cost to healthcare, more bureaucracy, stuff that's difficult to navigate through both on the patient side and on the doctor side as well, on the medical side. And the quality of care isn't necessarily better either. We're not getting this trade-off for our money.
Right. Yeah.
Okay. So besides the certificate of need things, any other like big glaring issues that we can solve in the next 3.5 minutes?
Well, the problem that we're facing with the American healthcare system is that it's so fragmented and it's so complex that there's no magic bullet. I mean, I wish there were a magic bullet. I wish we relied less on insurance across the board. I would be in favor of moving toward a concierge care kind of model where people pay more out of pocket for the care that they really want, as opposed to putting more of their money in third-party payer hands. But I think starting with these state regulations, right, really giving people the freedom to work. So reducing the burden of licensure, reducing the burden of certificate of need, reducing just, again, like even beyond the certificate of need, the Department of Health has just such intricate, onerous regulations. I have a PhD in political science and I tried to understand parts of the Department of Health website and I could not do it. So what are other people able to do, right? I've been working with a couple of midwives and doulas, and you have to hire a consultant to get through the certificate of need process. So it's become this industry of insiders providing insider information, and everyone else pays for it. And the consultants are wonderful people. They actually, like, this is not against, being a consultant, but it's crazy that you have to pay somebody to tell you what your state's regulations require in order to open a small business.
Right. It's just so complicated. How do you navigate it on your own?
Yeah.
No, it is. And then the incentive for politicians too, I'm sure, is just like, well, these medical professionals tell us this is all necessary, so we're going to keep adding this stuff in, right? They don't know how to run this stuff, so they add more laws and it'll be fine.
Well, it's a little bit more nefarious than that. So if you look at, there was actually a couple articles that came out recently as a result of the Cuomo nursing home scandal, and it looked at how much money he's received from the New York Hospital Association in the last, or the Greater New York Hospital Association. And so, I mean, he's received at least $1 million, if not more, from them in the past, for the last election cycle. And then lots and lots more from smaller medical associations. So it's a cronyist system. It's not just because politicians trust doctors to know what's right. It's the fact that the hospital associations are lobbying actively to keep out competition, and they're doing so with very deep pockets.
Wow. All right. So we only have about a minute left. Again, we're joined by Dr. Lauren Hall, who's a professor of political science, RIT, and author of The Medicalization of Birth and Death. Lauren, do you have anything to plug before we go?
Other than the fact that I actually do touch on a lot of reforms at the end of the book. You can find it on Amazon. And it's The Medicalization of Birth and Death. But that's it. Thanks so much for having me.
All right. Thanks for being on. And thanks for listening, folks, here on A Free Solution. We're going to be back on Friday. Appreciate you listening, and take care.